All right, so we're going to talk about lymphoma today. Not a terrible amount to learn here, but there's definitely some high yield stuff mixed in here that may come up on your exam. So as always, I'm going to focus on the stuff I feel like is going to come up, and I will not waste your time with the stuff that I feel like is not. Big thank you as always for all of the really nice comments. I really do appreciate the support, and you all are really just so nice. So thank you again for that. Let's go ahead and get started with lymphoma. Let's start with the basics and break down what lymphoma means. So lymphoma. Lymph stands for your lymphocytes. Oma stands for tumor. So we have a tumor derived from lymphocytes. Okay, so that's what that means. What about Hodgkin versus non-Hodgkin? What's that all about? All that means is either you got Reed-Sternberg cells or you don't have Reed-Sternberg cells. So Hodgkin, you got Reed-Sternberg cells. Non-Hodgkin, you do not. That's all that means. And we will go down and break down what a Reed-Sternberg cell is in a little bit, but just know that lymphoma, tumor derived from lymphocytes. Hodgkin, you have Reed-Sternberg cells. Non-Hodgkin, you do not. All right, now that we've broken down the basics, let's break down each individual one. Let's start with Hodgkin lymphoma. I feel like this is the one that comes up more often. It's got a lot of the buzzwords and different things like that that you need to know. So Hodgkin lymphoma, this is a hematologic malignancy of mature B cells originating in the lymphatic system. So you have a B cell, it has this abnormal gene rearrangement. Due to this abnormality, instead of the cell going through apoptosis, which is your programmed cell death, the cell does not do that and just decides to divide uncontrollably, which leads to this neoplastic cell and enlargement of the lymph node, and other clinical manifestations we'll go over in a second. Now, this is your most important thing to know, which I just went over, presence of Reed-Sternberg cells. That is pathognomonic for Hodgkin lymphoma. You need to know that. It's what differentiates Hodgkin from non-Hodgkin, is the presence of those Reed-Sternberg cells. What are Reed-Sternberg cells? Well, there are these multinucleated cells, usually binucleated, so two nuclei fused together, and the two nuclei next to each other actually look like owl eyes, and that's why sometimes you'll see it described as having an owl eye appearance on microscopy. So remember, Hodgkin, you got Reed-Sternberg cells. Non-Hodgkin, you do not. FYI, not important for the exam, but just so you know, it's possible to have the presence of a mononuclear variant of Reed-Sternberg cells. These are just called plain old Hodgkin cells. So let's take a look at what they actually look like. So these are your Reed-Sternberg cells. Those kind of look like owl eyes, those two nuclei put next together. That's why they're called, also known as owl eyes, Reed-Sternberg cells. All right. Next important thing for you to know, this has a bimodal age distribution. So you need to know, you can see this in young people and you can see this in old people. It has a bimodal age distribution. So there's going to be a peak in late adolescence, young adulthood, and then a second peak in older adults. Okay, contiguous spread to local lymph nodes, better prognosis. What's going on here? So in Hodgkin lymphoma, dissemination generally proceeds from a single lymph node region to an adjacent lymph node. This is good. We don't want it to be in one lymph node and then the next day in the abdomen, spread really fast all over the place. Hodgkin lymphoma, and the reason why it has a better prognosis, normally goes from local lymph node to the next. So it normally doesn't spread very far. Extranodal spread, like we see in non-Hodgkin, is not common in Hodgkin. So that's why it has a better prognosis, contiguous spread. Risk factors. There's a few different risk factors, immunosuppression, etc. The only one I think you should commit to memory, the one that seems to come up a lot, is Epstein-Barr virus. So Epstein-Barr virus has an association with Hodgkin lymphoma, and it's usually something they like to mention in the vignette, so look out for that. Now, in an immunocompetent patient, a healthy patient, it's not really that common, but in patients with HIV, AIDS, or other immunosuppressive conditions, almost all Hodgkin lymphoma cases in this patient population are EBV positive, so really common in that patient population. Now types, just like with risk factors, there's a bunch. I don't want you to know all of them. I think it's a waste of time. There's only one I would say to maybe commit to memory, and it's just because it's the most common variant of classic Hodgkin lymphoma, and that's nodular sclerosing. Again, that's your most common type. Close to 70% of cases of classic Hodgkin lymphoma is nodular sclerosing. Clinical manifestations, 3 things that you should know. First one, most important, it's going to be non-tender lymphadenopathy. Neck being your most common site. In all of lymphoma, non-tender lymphadenopathy, that is what you are looking for. It's going to be your most common presentation for a patient with Hodgkin lymphoma, seen in more than 2/3 of patients at presentation, and the involved lymph nodes are generally going to have a firm, rubbery consistency, and then that important word, non-tender. That's the key, because that separates it from what's known as reactive lymphadenopathy. That's going to be your painful lymphadenopathy that you have during an acute infection. This is not going to be generally painful. And again, the neck is going to be the most common site of involvement. 60 to 80% of patients will have enlarged cervical and/or supraclavicular nodes. One final interesting note that's really very bizarre, but in patients with Hodgkin lymphoma, as I said, normally those lymph nodes are non-tender, they don't hurt. But if these patients drink even a small amount of alcohol, within minutes, these lymph nodes become painful. Doesn't happen in every patient with Hodgkin lymphoma, but it's extremely specific to Hodgkin lymphoma. I wouldn't recommend it for your clinical exam or when you're doing an exam on a patient to kind of make the diagnosis, have them drink a little bit of alcohol and see if it becomes painful. But it's interesting to note that this does happen. The patho behind it isn't really understood, but it's something to look out for. They may come up in an exam question too. Mediastinal mass. So discovery of a mediastinal mass on routine chest x-ray is another common presentation for Hodgkin lymphoma. Patient may come in with cough, shortness of breath, retrosternal chest pain. You do a chest x-ray and then all of a sudden you notice this mediastinal mass. It's another common presentation for Hodgkin lymphoma. And then finally, B symptoms. So fever, night sweats, weight loss, your constitutional or B symptoms are much more common in Hodgkin lymphoma compared to non-Hodgkin. Now, most patients walking in early on in the disease aren't going to have this, but around 50% of patients with advanced disease will have these B symptoms, which are actually caused from cytokine release from those malignant cells. Diagnosis is not very difficult. There's really two things you need to know for diagnosis. That's going to be biopsy and imaging to stage it. So first you cut it out to confirm the diagnosis, then you do some imaging to stage it and see how far along they are. Now, as far as the cutting it out part, that's going to be done with an excisional biopsy of the affected lymph node. Now, you may see FNA, a fine needle aspiration, as one of your answer choices. That's not going to be your answer. It generally does not provide sufficient enough tissue. So normally you will do an excisional biopsy to make the diagnosis. You find an affected lymph node, cut it out. What are you looking for on the biopsy? Reed-Sternberg cells. So those bi or multinucleated cells that look like owls. And then as far as your imaging to stage, you're generally going to do that with a PET CT. Treatment, unlikely you're going to get a question on treatment, but just know it's a combo of chemo and radiation. These chemo regimens are so intense. There's so many things involved. It's beyond your scope of practice. So if they asked you any regimen, likely what you'll see is something known as ABVD. I don't even think they will ask you this, but this is one of the more common regimens used for Hodgkin lymphoma. It's a combination of adriamycin, which is the brand name for doxorubicin, bleomycin, vinblastine, and dacarbazine. It's usually carried out for 3 to 4 cycles and then followed by radiation therapy. Again, I don't think you'll get a question about treatment, but if you did, just be aware of that ABVD combo. There's a lot of stuff to know for Hodgkin lymphoma. So how am I going to give you a way to remember this? What I'm going to have you try to remember is that Hodgkin lymphoma is all about the B cell. So remember the B cell. So B cell malignancy. B cell malignancy originating in the lymphatic system. Second B. B symptoms, more common in advanced disease, fever, night sweats, weight loss. EBV infection. Remember the relationship between Epstein-Barr infection and Hodgkin lymphoma. Next B is binucleated cells. Remember those are your Reed-Sternberg cells, bi or multinucleated cells. Those are the ones with 2 or more nuclei that look like owl eyes. Bimodal distribution, remember young and old patients. And then the last one is bound in place. Remember this has the better prognosis. It's usually localized. Extranodal spread is rare. So that is your Hodgkin lymphoma. Let's move on to non-Hodgkin lymphoma. This is going to be a heterogeneous group of malignancies of the lymphoid system derived from B and T cells. Remember when we talked about Hodgkin lymphoma, we were focusing on B cells. Well, non-Hodgkin can be B or T cells. B cells are much more common, though, about 80 to 85% of the cases, but remember, it can be either one. Very important, absence of Reed-Sternberg cells. Remember, Hodgkin was all about the Reed-Sternberg cells. Non-Hodgkin, no Reed-Sternberg cells generally. And this is why your diagnosis is normally, or your prognosis is generally poor in these patients, because you have a hematogenous or non-contiguous spread. So in Hodgkin lymphoma, we talked about spreading contiguously from local lymph node to the next local lymph node, which is why it had a better prognosis between the two. But non-Hodgkin, unfortunately, can have a hematogenous spread, which is a spread through the blood. And this is why we usually see poor prognosis in these patients, because you can have extranodal spread involved in the GI tract, the brain, the skin. And that's why sometimes, actually in non-Hodgkin lymphoma, you may see it referred to as a type of leukemia, because the abnormal cells escape these solid lymph nodes and get into the bloodstream. So remember, it can spread. Normally, GI tract is going to be the most common place for it to spread to, that extranodal spread. Types, just like in Hodgkin lymphoma, there's a bunch of different types of non-Hodgkin lymphoma, and in this case, unless you're going to specialize in hematology, I think you should only focus on two that you're likely going to get tested on, and those two are going to be diffuse large B-cell and Burkitt lymphoma, emphasis being on Burkitt lymphoma since it seems to come up so much. So again, diffuse large B-cell, the only reason I'm mentioning this one is because it's your most common subtype. Really not a lot to know about it, really no buzzwords or anything special to know. Just know that diffuse large B-cell is your most common subtype of non-Hodgkin lymphoma, accounts for around 25% of adult non-Hodgkin cases, and it's very aggressive and fast growing. Now let's talk about the important one, which is Burkitt lymphoma. So if you're going to remember one thing about non-Hodgkin lymphoma, remember Burkitt lymphoma. It always seems to come up on exams. So what do you need to know about this highly aggressive subtype of non-Hodgkin lymphoma? There's three things that I want you to remember. First one, if you do a biopsy on these patients with Burkitt lymphoma, you're going to see it described as a starry sky appearance on biopsy. Definitely know that. This is caused from numerous benign macrophages, your histocytes. They've ingested tumor cells, and they're called these tingible body macrophages. It doesn't matter. Don't worry so much about what creates the starry sky appearance. Just know if you see starry sky appearance mentioned on a biopsy, right away be thinking of Burkitt lymphoma. Second thing, and that's your Burkitt lymphoma. That's what it actually looks like here. So you can see, I guess this is what they describe as a starry sky appearance. You see the lighter cells here on that dark background. That's why they call it a starry sky appearance. Next thing, Epstein-Barr virus. So in Burkitt lymphoma, chronic Epstein-Barr virus infection plays a really big role, particularly in the endemic African subtype of Burkitt lymphoma, which is very common to see this. So remember, if we're talking about non-Hodgkin lymphoma, generally Epstein-Barr virus does not play a huge role, but if you're talking about Burkitt lymphoma, definitely be thinking Epstein-Barr virus. Third thing, jaw or facial bone tumor. So the endemic African form presents with in up to 60% of patients can present with a jaw or facial bone tumor. It doesn't seem that important, but this definitely comes up. So remember Burkitt lymphoma, be looking for them to mention jaw swelling or pain. It always seems to come up. And this is what this actually looks like, unfortunately, in a patient with Burkitt lymphoma. You can see the really large amount of swelling here on the side of the face. So that's that jaw malignancy, the facial bone tumor in these patients. All right, so I think this is really important for you to remember all of the different things with Burkitt lymphoma. And it was always hard for me to remember this. So what I came up with for Burkitt lymphoma, when you see Burkitt lymphoma, the first thing I want you to do is, instead of remembering it as Burkitt lymphoma, I want you to remember it as Burkitt lymphoma, like think of a kite. So as soon as you think of Burkitt, erase that from your mind, think of Burkitt lymphoma. Why Burkitt lymphoma? So this is what we're going to go through here. So hopefully this helps you. It's a visual that I really have never forgotten. So as soon as you see Burkitt, think of Burkitt. Think of a guy kite surfing in the middle of the ocean. Right away, this is your visual that you see. Now he's kite surfing in the middle of the ocean, but it's not the middle of the day. It's actually the middle of the night. And what do you see here? All of a sudden you see all of these stars in the sky because it's the middle of the night. So Burkitt, you're thinking of a guy kite surfing in the middle of the ocean in the middle of the night, starry sky appearance. All right, next thing. He's in the middle of the ocean and then all of a sudden a shark pops out, but it's not just any shark, it's Jaws. So that helps you remember jaw involvement in your Burkitt lymphoma. So middle of the night kite surfing, Jaws circling him. Next thing. He is surfing off the coast of Africa. And if you know anything about Africa, you'll know that it's actually the most common place for shark attacks to occur. So it makes sense that Jaws is circling him. And that helps you remember your endemic African subtype of Burkitt lymphoma presents with the jaw malignancies as well as Epstein-Barr virus. And the way you remember that is this guy is kite surfing in the middle of the ocean. And this thing he's holding here is actually known as a control bar. That's the real name for it. So you see he's holding a bar surfing. That helps you remember Epstein-Barr virus. So this seems like a lot and ridiculous that you're not going to remember it. But you will. Just kind of remember as soon as you see Burkitt lymphoma, just think of a kite. Remember a guy kite surfing, he's holding onto a bar, Epstein-Barr virus. He's being circled by a shark, Jaws. jaw malignancy. You remember he's surfing off the coast of Africa where most of the shark attacks occur. That helps you remember your endemic African subtype. You remember he's kite surfing in the middle of the night, starry sky appearance on biopsy. Hopefully that will help you remember the couple of things you need to know. Worst case, if you just remember as soon as you see Burkitt lymphoma, think of a kite in the middle of the sky at night, you can remember your starry sky appearance, and that might be enough to get the question right. Anyways, let's move on with non-Hodgkin lymphoma. So next thing that we want to talk about is your clinical manifestations. First thing, just like I said before, with Hodgkin lymphoma, you're going to have, again, your non-tender lymphadenopathy. So lymphadenopathy, generally firm and painless. It's going to be present in more than 2/3 of patients with non-Hodgkin lymphoma at presentation, same as in Hodgkin. But what you need to focus on for clinical manifestations for non-Hodgkin is the extranodal involvement. That's really important here, and that's what's different. Most common area for extranodal involvement is going to be the GI tract. So this is something that's more common in non-Hodgkin's, but like I said, not common in Hodgkin lymphoma. Remember, Hodgkin lymphoma was bound in place with a contiguous spread, whereas non-Hodgkin's can spread, can travel and spread throughout the body non-contiguously. The most common place, like I said before, GI tract. So they may present with a bowel obstruction. Skin is going to be your second most common area. So you want to make sure you carefully examine the skin, and any suspicious area should be biopsied for the presence of lymphoma in these patients. And then in males, testicular non-Hodgkin lymphoma constitutes 1% of all cases. So be aware, non-Hodgkin lymphoma can definitely spread. Main area of the exam, though, to look out for is going to be the GI tract. Now, what you may see that I didn't mention is B symptoms. So a patient with non-Hodgkin lymphoma can definitely have B symptoms in real life, but it's not as common in Hodgkin lymphoma. So for the sake of the exam, if you see B symptoms, I want you to be thinking more of Hodgkin lymphoma rather than non-Hodgkin. Not in real life, because you can definitely have it in either, but for the sake of the exam, be thinking more Hodgkin rather than non-Hodgkin if you see B symptoms noted. Diagnosis, again, just like in Hodgkin, there's not a lot to know here. Cut it out, biopsy it, and stage it with imaging. So excisional biopsy, PET CT for staging. Treatment, again, likely I don't think you're going to get a question about treatment, but just remember it's a combination of chemo and radiation. The most common chemo regimen for non-Hodgkin is going to be something known as R-CHOP. That's the way we remember it. And what that stands for is rituximab, cyclophosphamide, hydroxydoxorubicin, which is another name for doxorubicin, and oncovorin, which is the brand name for vincristine, and then prednisone. So it's ridiculous to remember all of those, but if you can remember R-CHOP, and for some reason they're evil and they give you a question on the treatment regimen for non-Hodgkin lymphoma, you could probably get there with the R-CHOP. So what do you need to know? There's really just a few things that I feel like if you're going to forget everything, you remember these few things, you'll be all right. So remember, no Reed-Sternberg cells. Remember, this can spread. You can have extranodal involvement, especially the GI tract. And then remember the few things about Burkitt, aka Burkitt lymphoma. And I think you'll be all right and get the question right. All right, so I wanted to do a side-by-side comparison of Hodgkin and non-Hodgkin lymphoma just so we can briefly go over the differences. So let's take a look at the chart and see. So Hodgkin versus non-Hodgkin. Remember, Hodgkin, you're going to have your Reed-Sternberg cells. Non-Hodgkin, you're not. Remember, that's probably the most important thing to remember. Hodgkin, remember, contiguous spread, not really spreading that far usually, better prognosis. Non-Hodgkin, you have your extranodal manifestations, extranodal spread, non-contiguous. Hodgkin lymphoma, remember, B symptoms are more common. Non-Hodgkin, it can definitely happen, but generally not as common as in Hodgkin lymphoma. Hodgkin lymphoma, remember, nodular sclerosis is your most common type. Non-Hodgkin, we're looking more at diffuse large B cell as our most common type. Hodgkin lymphoma, the regimen for chemo is going to be your ABVD regimen. Non-Hodgkin, R-CHOP regimen. And then Hodgkin lymphoma, think of EBV infection. Non-Hodgkin lymphoma, if you see EBV, you should be thinking Burkitt. It can happen in the regular variants, but if you get it on a question choice, they're almost definitely talking about Burkitt lymphoma. All right, so let's do a few questions and see what you can remember. First question, 32-year-old male presents to the office today with pain and swelling in his jaw for the past few months. Upon obtaining history from the patient, you learn he recently moved here from South Africa about 6 months ago. On physical exam, non-tender submandibular and axillary lymph nodes are palpated, and a large mass is visualized on the right lower side of the mandible. Lymph nodes are biopsied, which display large bright histocytes scattered throughout a background of the darker basophilic tumor cells, almost creating the appearance of stars in a dark sky. What is the likely diagnosis in this patient? So hopefully on an exam they're as nice as I was and gave you every single buzz term and word that you need to know. But that, of course, is Burkitt lymphoma. So you have a patient that recently moved here from Africa, which we know is where the endemic form of Burkitt lymphoma is located. Next, describes jaw pain. We know that in 60% of cases of endemic Burkitt lymphoma, they involve the jaw and facial bones. Non-tender lymphadenopathy on exam. Finally, the starry sky appearance on biopsy. All the key findings in Burkitt lymphoma, which is a common subtype of non-Hodgkin lymphoma. Remember, it is not Burkitt lymphoma, it is Burkitt lymphoma. Remember that guy kite surfing in the middle of the ocean, jaws circling him, holding onto the bar with the starry sky in the middle of the night, and he's surfing off the coast of Africa. All right, question 2. What is the most common type of Hodgkin lymphoma? That is going to be your nodular sclerosing in about close to 70% of cases. Question 3. Large or multinucleated cells, sometimes referred to as having an owl-eye appearance on histology, commonly seen in Hodgkin lymphoma, are known as, and for some reason I put the answer there, and that's Reed-Sternberg cells. Sorry about that. Question 4. Probably knew that one anyways, though, so I don't think I ruined anything there. Question 4, a 22-year-old female presents at the office today complaining of persistent fever and unexplained weight loss. On physical exam, non-tender lymphadenopathy is noted. A biopsy is obtained of the affected lymph nodes, revealing Reed-Sternberg cells. The painless lymph nodes palpated on exam were likely located in which part of the body in this patient? So where were those non-tender lymph nodes likely located in this patient? It's going to be the neck, the cervical, the supraclavicular area. So this patient has Hodgkin lymphoma, evident by the non-tender lymphadenopathy, B symptoms, then of course Reed-Sternberg cells, which are pathognomonic for Hodgkin lymphoma. That's all you needed to really know this was Hodgkin. And then in Hodgkin lymphoma, as I went over before, the neck is the most common site for lymphadenopathy, with about 60 to 80% of patients having enlarged cervical or supraclavicular nodes. Question 5, a 57-year-old female presents to the office to review the results of her recent imaging test she had done after being diagnosed with non-Hodgkin lymphoma. The results of the PET-CT reveal that the lymphoma has spread. Which area of the body will likely show extranodal involvement on the PET-CT? So that is going to be the GI tract. So that's the most common site of extranodal disease in non-Hodgkin lymphoma is the GI tract. And remember, extranodal disease is much more common in non-Hodgkin lymphoma compared to Hodgkin lymphoma, where extranodal spread is rare. All right, so that is lymphoma. Thank you so much for watching the video. If it was helpful, please let me know. And as always, good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.